Hello friends, today we'll be discussing about testicular tumors. Before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. These notes are very helpful for quick revision. So without further delay, let's get started. So before starting, let's see the anatomy of testis, where we have the outer layer as tunica vaginalis, inner layer that is tunica albuginea, and it is secured by ligamentous remnant of processa vaginalis. And then we have the lobules, which contain the uh, various seminiferous tubules. So these lobules will connect to the retitestis, and retitestis will connect to the epididymis, and epididymis will connect to the ductus deferens. So, and these lobules, 200 to 300 lobules, having seminiferous tubules, which will be connected to straight tubules. Then it will be connected to the retitestis. Then they will connect to the efferent ductule, then to the epididymis and ductus deferens. Also, the epididymis has a head, body, and tail as parts of the epididymis. Now, the blood supply is through the testicular artery, and collaterals through the cremastric artery and artery to vas, venous drainage through the pampiniform plexus. Then going through the gonadal veins, the right side will go in the IVC and the left side will be going in the left renal vein. Lymphatic drainage is to the retroperitoneal nodes. So these are retrocaval, paracaval, precaval, interaortocaval, preaortic and paraaortic. Mainly from L1 to L3, and pelvic and inguinal nodes are not regional nodes, but if involved, there is a history of transscrotal surgery is positive. Now the epidemiology, most common malignancy in men of age 15 to 35 years of age group, and germ cell tumor are the most common tumors, accounting for 90 to 95% of the tumor, and 35 is the median age of diagnosis. Non-seminomatous germ cell tumor are in the third decade and seminomatous in the fourth decade. The age modality, trimodal age modality from 2 to 4 year, 20 to 40 year or more than 50 year. For more than 50 year, lymphoma is more likely. 50% will be bilateral and will have LDH increased. Now we'll see the risk factors. So risk factors are cryptorchidism. So 7 to 10% of the cryptorchid testis will have tumors. Maximum for the intra-abdominal testis, and risk of malignancy is increased in the contralateral testis. So prepubertal orchidopexy decreases the risk of malignancy and age before 13 years of age. Klinefelter syndrome, family or personal history. If brother or father is involved, it is more risky when the brother is involved. Then ITGCN, that is intratubular germ cell neoplasia, which is not a precursor for yolk sac teratoma or seminoma, spermatocytic seminoma, and it has isochrome 12p and c-KIT mutation, managed through orchidectomy, low-dose radiotherapy, and observation. And lastly, trauma, viral infection, and environmental estrogens. Now the classification, it is classified initially into germ cell or sex cord stromal tumor or unclassified. The germ cell are further classified into intratubular germ cell neoplasia, seminoma and non-seminomatous germ cell tumor. Seminoma are classified as classical, anaplastic and spermatocytic. Non-seminomatous germ cell tumor, that are the embryonal carcinoma, yolk sac tumor, polyembryoma, trophoblastic tumor, and teratomas. Then we have the sex cord stromal tumor, Leydig cell, Sertoli cell, granulosa cell, thecoma, fibroma, and mixed. The unclassified will be gonadoblastoma, mixed germ cell, and sex cord stromal tumors. Now seeing the common ones in slight detail, that is seminoma, which is the most common testicular tumor. Types is classical, anaplastic and spermatocytic. Classical, most common, fourth decade, homogeneous. There is no hemorrhage or necrosis. Positive for CD117 and PLAP. Negative for CD13. Then anaplastic, that is 5 to 10%, more than 3 mitosis in upper hyperphily, nuclear pleomorphism is positive. Spermatocytic, that is 5 to 10%, old patient, slow growing tumor, no metastasis. Tumor markers AFP and LDH are normal, HCG is normal but may be increased in 10 to 15% cases. The next, which is second most common, is the embryonal carcinoma. It has pleomorphism, mitosis, and giant cell, variegated appearance with areas of hemorrhage and necrosis. It is very aggressive, invades cord and epididymis. It is totipotent, can differentiate into other types of non-seminomatous germ cell tumor, and it has AFP and beta HCG positive. Others like yolk sac tumor, which has pure form in kids, mixed form in adults, raised AFP, normal HCG. It has Schiller dual bodies, which has glomerular pattern, and mesodermal fold with central capillary. Then choriocarcinoma, which is rare and aggressive. Increased HCG, presents a disseminated disease in lungs and brain. Primary is usually small, often with no testicular enlargement. Hemorrhage in lung and brain causing death. Teratoma, derivative of the two or more germ layer with varying degree of differentiation, could be pure, immature, mature, and mixed. There could be AFP, raised, mucinous, cyst, and heterogeneous, and these teratoma are chemoresistant. Extragonadal GCT in the mediastinum, retroperitoneum, sacrococcygeal, or CNS. Mediastinum, it could be truly ectopic. Most common is seminoma, retroperitoneal, usually have testicular primary, and CNS could be in pituitary and pineal gland. Then the sex cord stromal tumor, that is Leydig cell tumor, which is the most common non-germ cell tumor with bimodal age group distribution. First in the 5 to 10 years age group, second in the 25 to 35 years age group. Small yellow well circumscribed tissue in the lesion. It has Renke crystals, which are cytoplasmic inclusion, and these secrete testosterone. Then the other is the Sertoli cell tumor, which is rare, bimodal. First is the less than 1 year, then 20 to 45 years, gray white with cystic component. It has virilization and gynecomastia property. Lastly, gonadoblastoma, which is very rare, mixed germ cell sex cord stromal tumor, gonadal dysgenesis. 80% will be phenotypically females and age is less than 30. Now the presentation, most commonly these present as painless testicular mass, which is firm to hard and non-transilluminant, and they considered as cancer unless proven otherwise. May have pain sometimes, though very less common, due to hemorrhage or infarction. more common in non-seminomatous germ cell tumor than seminoma. Always rule out epididymoorchitis, treat with antibiotics, and then reevaluate after 2 to 4 weeks. Then symptoms due to lymph node metastasis could be retroperitoneal lymph node causing back pain, psoas muscle involvement, nerve roots causing radiculopathy, then IVC compression resulting in lower limb swelling, DVT, present as abdominal mass, and in the neck can cause supraclavicular nodes causing neck mass, distant mets, lungs, dyspnea, chest pain, cough, hemoptysis, CNS in the form of neurological deficit and seizure, endocrine, that is gynecomastia due to increased HCG, low androgen and high estrogen, especially in the Leydig cell tumor, then decreased fertility and virilization. Now we come to evaluation. Now the evaluation, the initial examination will be scrotal USG, which is part of clinical examination with the 5 to 10 megahertz probe, that is the high frequency transducer. There is bilateral in 2% cases, and 0.5% of all GCT will be bilateral at diagnosis. Then it is homogeneous in seminoma and heterogeneous in non-seminoma GCT. The tumor marker, which is a separate question, very important topic, that is, it could be oncofetal substances or cellular enzymes. The oncofetal substance like the alpha fetoprotein, a beta HCG, and cellular enzymes like LDH. Now see one by one, that is alpha fetoprotein. Normally it is less than 16 nanogram per ml. The half is 5 to 7 days. It is elevated in embryonal carcinoma, teratocarcinoma, teratoma, and yolk sac tumor and mixed tumor. It is not raised in pure seminoma and pure choriocarcinoma. Next is the beta HCG. Normally is less than 5 international unit per liter. T half is 24 to 36 hours. Elevated in choriocarcinoma in all cases, that is 100%, embryonal cancer in 60% cases, teratomas in 55% cases, yolk sac tumor in 25% cases, seminoma in 7% cases. Then we have LDH, that is isoenzyme 1. Normally it is less than 333 international unit per liter. T half is variable. Seen in metastatic seminoma in 80% cases and metastatic non-seminomatous germ cell tumor in 60% cases. And placental alkaline phosphatase PLAP, that is T half is less than 24 hours, increased in 50% cases of seminoma at presentation. So when do we do these tumor markers? These are done specially for the germ cell tumors and specially done at presentation to confirm diagnosis, first week after orchidectomy for staging, and after completion of therapy at regular intervals for surveillance and follow-up. Now starting with the management, that is the radical inguinal orchidectomy, RIO. When we suspect a testicular neoplasm, we go for RIO, that is initial diagnosis and treatment procedure of choice. Then removal of the tumor bearing testicle with spermatic cord to the level of the internal inguinal ring. So it is high inguinal orchidectomy. Transscrotal orchidectomy or biopsy is contraindicated. Histopathology will tell us the type, size and invasion, multifocality, intratubular germ cell neoplasia, lymphovascular invasion. So biopsy or transscrotal orchidectomy is contraindicated because it alters lymphatics, and inguinal pelvic lymph node mets resulting in metastasis distance leaves inguinal spermatic cord intact where there is chance of recurrence. Then testis sparing surgery, generally it is not justified. Especially when there is contralateral normal testis. It may be considered when there is bilateral testicular tumor in the young patient with or patient having tumor in a solitary testis. Then if the tumor is less than 2 to 3 centimeter involving less than 30% of the testicular volume, suspected benign lesion less than 3 centimeter, that could be Leydig or Sertoli cell tumor. In these cases, we can consider testis sparing surgery. Contralateral testicular biopsy in patients with increased risk for intratubular germ cell neoplasia or testicular volume less than 12 ml, cryptorchidism, suspicion in ultrasound. And here we go for open inguinal biopsy through the Chivasiv manner, through the inguinal approach, clamp the testicular vessels, explore testis and take biopsy. Imaging for metastasis through the abdominopelvic CT, CCT oral plus IV contrast, retroperitoneal nodes, size, number and location, retroperitoneal vascular anatomy, anomalies of the retrocaval right ureter, others like chest X-ray, chest CT for lung and mediastinal GCT, bone and brain scan if needed. If symptomatic, brain scan is important for choriocarcinoma or cases with increased beta HCG. Now the staging, that is the clinical staging. Clinical stage 1 confined to testis. TIS is intratubular germ cell neoplasia. T1 when limited to testis and epididymis, no lymphovascular invasion. T2 where there is involvement of tunica vaginalis with lymphovascular invasion. T3 spermatic cord invasion with or without lymphovascular invasion. T4 that is scrotum invasion with or without lymphovascular invasion. Now CS2 that is clinical stage 2, that is regional retroperitoneal nodal involvement. So it is A, B and C where A is lymph node less than 2 centimeter and it is N1 in pathological staging. Stage 2 is 2 to 5 centimeter and it is N2 in pathological staging, and 2C is more than 5 centimeter and N3 in pathological staging. Now clinical staging 3, that is non-regional lymph nodes or distant mets. So it is M1A when there is pulmonary or non-regional metastasis, M1B where other distant metastasis. Now serum marker, tumor marker staging. So AFP stage 1 will be less than 1K, HCG along with AFP will be less than 5 international unit per liter and LDH will be less than 1.5 times upper limit of normal. So all these three will be S1 for serum marker staging. Now stage 2, that is AFP will be 1000 to 10,000 or HCG will be 5,000 to 50,000 or LDH will be 1.5 to 10 times upper limit of normal. And in S3, that is AFP will be more than 10,000 or HCG more than 50,000 or LDH more than 10 times upper limit of normal. And these are based on the post Rio radical inguinal orchidectomy tumor marker levels and not levels at the diagnosis. Now differentiating between seminoma and non-seminomatous germ cell tumor. So the presentation is early in seminoma, late in non-seminoma, occult mets are low in seminoma, high in non-seminoma, relapse is low in seminoma and high in non-seminoma. Tumor markers generally negative, may be positive in seminoma but always increased in non-seminoma. Tumor marker levels in mets, it may not be increased in seminoma but it is definitely very high in non-seminoma. Chemosensitivity is high in seminoma and non-responding in non-seminoma. Radiotherapy is active in seminoma and non-active in non-seminoma but helpful in brain mets. Risk of teratoma at metastatic sites is decreased and increased in non-seminomatous germ cell tumor, non-seminoma. Likelihood of requiring post-chemo surgery is low in seminoma and high in non-seminoma. Now we see the management after radical inguinal orchidectomy. For clinical stage 1 in seminoma, we have option of surveillance, primary radiotherapy to retroperitoneum or ipsilateral pelvis, primary chemotherapy, single agent that is carboplatin. In non-seminoma, surveillance, especially for very low risk tumor. In high risk, like the embryonal component or lymphovascular invasion, we go for either retroperitoneal lymph node dissection, that is primary RPLND with full template nerve sparing dissection, or primary chemo, that is bleomycin, BEP, etoposide, and cisplatin. In clinical stage 2A and B, in seminoma, we go for dogleg radiotherapy and first line chemotherapies, that is BEP or EP. In non-seminoma, we have either primary retroperitoneal lymph node dissection with or without adjuvant chemo, or induction chemo followed by post-chemo RPLND. In clinical stage 2C and clinical stage 3, in seminoma we go for chemo, and in non-seminomatous we go for chemo, that is BEP, VIP in high risk patient, that is vinblastine, ifosfamide, and cisplatin. Then RPLND, that is retroperitoneal lymph node dissection, that is standard retroperitoneal lymph node dissection. We dissect all the 5 lymph nodes seen, that is pre-aortic, para-aortic, aortocaval, pre-caval, paracaval, and along with that we also go for common iliac nodes. In nerve sparing, we prevent L1 to L4, that is post-ganglionic efferent sympathetic fibers, to prevent antegrade ejaculation, to which influence the antegrade ejaculation, and to prevent retrograde ejaculation. It is avoided in choriocarcinoma. So this was all about testicular tumors. So thank you for watching. Please like, share, and subscribe. Keep studying, keep growing, and never give up, because great things take time. See you in next video. Thank you for watching.